And good morning. This is Dr. Deuk. We are broadcasting live from the Deuk Spine Institute, spine surgery being performed March 28, 2023. Our patient is actually local from Florida. He's from St. Pete, the other side of the state. He has back pain that's quite horrible coming from two discs, the L3-4, L4-5, and his facet joints on the right side, L4-5, L5-S1. So we're going to be treating the two discs, which are herniated discs, spondylolisthesis, stenosis. We're treating that with the Deuk laser disc repair, and then we're going to treat his facet joint pain with the Deuk plasma rhizotomy. All right, let's go ahead and get started. Now, it's a bit unusual we're not doing L5-S1, because most of the time we are. L4-5 is the most common disc that is affected, and it's in almost 100% of our back surgeries, being a cause of back pain. I'm giving you some numbing medicine. The patient is awake. We're going to put him to sleep shortly, but I do need him helping me in the beginning. All right. Lay still. You're doing great. All right, we're not...
Okay, stay still.
Jordan.
You're doing great.
Is this our new floral?
Can you squeeze my hand here? Good. Okay. Just stay still.
No problem. All right, but you see we got a lot of space in front of the spine we don't need to be seeing. So let's get the floral right.
Nice and still. You're doing great, my friend.
All right, so you got to drop the table. Okay. I mean, Jordan, you should be talking to him. Don't collimate, drop. All right, unless it's too much. It's way too much. Come on, guys. You know these changes are small. Right back where we started. Good. That's good. Yep. All right. So I don't like that angle of approach. How come our pressure is 140? We didn't use any epi, right? Shot? Okay. A lot going on. First, I'm going to access the L4-5 disc with a transforaminal approach. Everything's good. Lay still. You're doing great. He's not moving, but I just want him to stay that way. You can see the approach of the needle coming in from the side. It's actually a nice trajectory that's a little too high. So I have to reposition a little lower. Lay still. Don't move. Uh-huh. Very nice. Shot. All right. So you can see the tip of the needle. Jordan, show our audience the tip. All right. Very good. And you can see the neural foramen. Show them the foramen. You can actually see the herniation on this x-ray. You guys see the herniated disc? And there's one more thing I want to show you, and that is called spondylolisthesis. And I get this question a lot. Dr. Deuk, I've got spondylolisthesis. Show them. The back of the L4, should show them the back of the L4. There you go. Right there, up a little bit. There is the back of the L4. You see that? That's the L4 vertebral body. Circle the L4 vertebral body or rectangle it. Yeah, you ever think about that? What's the appropriate term if you're going to outline a rectangle? You have to say rectangle it, not circle it. All right, so rectangle L4 again. There it is. That's called the L4. No, that's too much. L4 vertebral body. Stay along the back side there. Right there is the back. Now look how the back of L4 drops down, and it doesn't line up with the back of L5. L5's back is a centimeter further back. So the L4 is actually slipping forward on the L5. You could also see it in the front of the spine, how the front of L4 is in front of L5. Should be lined up perfectly. Okay, that's lined up perfectly as normal, but that's not what we have today. So this patient has a spondylolisthesis, and the question I get from everybody is, can you still fix my back pain without fusing the spondylolisthesis? Because a lot of spine surgeons say you have to fuse spondylolisthesis to get rid of the back pain, and that is not true. It is absolutely not true. So actually, we're going to get rid of his back pain without fusing the spondylolisthesis. All right, I'm right up against his facet. I just want to make sure I'm tight on the facet. So I went back just a little bit and I'm redirecting. I'm just hugging that facet. Shot. And I'm sneaking around it. And I want to be just on that facet joint. You can feel a lot of bone spur and stuff there. Shot. All right, that's perfect right there. There's a little trick to doing this, and it requires that you capture some of the residual facet capsule.
Stay still.
Lay still.
You're doing great. You're doing great.
Any pain?
Yeah,
Where is
any
this pain?
anywhere? No pain. Shoot.
All right. Where do you have pain? I can feel the herniation, by the way.
Right where you're.
All right, not down your leg. Where do you feel it?
Where?
In your ass?
Yeah.
All right, good. That's your bad disc, my friend, Sean. That's the one we're going to fix, so just chill out. You're good.
You're doing great.
All right. So we are inside the first disc that we're going to fix, L4-5. You're doing great. We're going to put you to sleep soon. I just need you awake for a few more seconds here. All right? A little more local. Well, I don't disagree. I understand, but I thought we had already given it, so that's...
We did. We just need
no problem. We're just giving you numbing medicine. I know it's a bit uncomfortable. Just bear with us, okay? All right, so we've made a 7mm incision, and now I'm going to place his L3-4 needle. You're okay. Relax. Shot. All right, so we're heading for the L3-4, which is the second disc that we're fixing. Shot. You can see how arthritic his facet joint is, Jordan. Shot. Yeah, look at how, no, that's not it. Show the whole thing. All the way back. See the bone back there? There. Even further back than that. There. Yeah. The reason why it doesn't look like a solid piece of bone in the back is because it's not. It's all bone spur and not normal types of bone. Shot. There we go. Shot. All right, you're doing great. We're almost done. Shot. We're going to put you to sleep in just a minute, okay? Shot. All right, so here we are at the second herniation or second disc that we're fixing. You're okay. So I'm going to show you a quick video, and the video is going to show you why do discs actually cause back pain. Lay still. Stop moving. Okay, we need you to cooperate.
Thank you, my friend. We're right with you.
All right. Go ahead there, Henry, and show them the video on why do lumbar discs actually cause back pain.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. So now you know that a annular tear in the back of a disc can actually cause horrible back pain, and that's exactly what's causing his pain, along with the facet joints at L4-5 and L5-S1, which we're going to fix later. So we're going to test these and see how much pain they actually are causing. How bad is that on a scale of 1 to 10? What's the highest? 10. Is that where you typically get back pain? Is that where you typically get your back pain? I can't hear. Yes. All right. All right, you're doing great. Lay still. That and a little bit higher, he said. Do you guys see that? Think about that. Just think about the last statement he made. We're almost ready. He said, I get it at there, which was L4-5, and a little bit higher. That's exactly what Deuk Spine Institute selected as his 2 discs that were causing his back pain. I did L4-5. The next one we're doing is L3-4, and that is a little bit higher. So he is precise. Isn't it amazing? How bad is that on a scale of 1 to 10? 10? Is that where you typically get your back pain? All right, you're going to go to sleep. So let's talk about this for a moment, folks. He's had back pain for 40 years. 40 years. This poor man has suffered for 40 years. Think about that. He has had the quality of his life robbed for 40 years because of this problem that we fix in 30 minutes at Deuk Spine Institute. We're going to fix it permanently for the rest of his life. If he had found us 39 and a half years ago, then he could have had 39 and a half more years of no back pain. Now let's show the audience, how does the Deuk laser disc repair actually work?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. So now you can understand how the Deuk laser disc repair, the procedure done here at Deuk Spine, actually cures back pain that comes from a disc injury. And those disc injuries can be herniated disc, bulging disc, ruptured disc, protruded disc, extruded disc, slip disc, any of those conditions, degenerated disc, spondylosis, and as you can see, spondylolisthesis. We're going to get rid of his back pain without fixing his spondylolisthesis. It's all done through this tiny incision here. You guys see that? That is literally 7 millimeters, quarter-inch incision. No open surgery. All right, we're advancing the dilator down to L4-5 shot. I can feel the herniation. Hold on. Shot. Let's take the guide wire out. Shot. All right. We are inside the L4-5 disc. Relax, you're doing great. Now, what do you have inside the discogram material? You have some Marcaine. Lay still, you're doing great. Huh? All right, let's pull back a little bit on the dilator. Just a little bit.
You're doing great, my friend. Okay, stay down. You're doing fine.
Lay still, you're doing fine. So one of the challenges of these surgeries, huh?
Oscar, can I have right tech wet?
And pull them both back a little bit.
What do you need? Right tech wet, please. Thank you.
What do you,
Check.
shot? Pull them back. Yeah, a little bit more. So if we get it pulled back just a little more, and you're off on orbit, by the way. I don't know if you can see that, but the orbit is off. It's not a big deal. He's moving around a little bit. It's probably why. No, you're okay. I'm just talking to Jordan. Yeah, you need to go a little bit more. All right. So let's see that. All right. Try to, they should be separated or close to separated. Anyway, the challenges we're having here are that the patient, you need a wet Raytec, come on. Did you, okay, use your brain. What do you think we need at this difficult stage? What have we always needed, Oscar? A wet Raytec, Oscar, not a Raytec. Have you been paying attention? Has it ever been dry? Okay, it's always been wet. So why would you give us a dry Raytec? Of course it's on you. I'm trying to get you to think. I can't have people working for me that are not thinking. Shot. I get criticism because of the way I talk to some of my employees, but when you tell somebody something or show somebody something 10 times and they still don't do it right, that's on them. That shouldn't be on me. And, you know, an employee should pay attention and change what they're doing to do it right after the second or third time at most. So when people don't pay attention and keep making mistakes over and over again, you know, that affect patient care, I have to, as the CEO, founder, say something and do something. Shot. Okay.
Do you want me to
Move.
hold these? And then
Shot. 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 In the end, I'm responsible for this patient's well-being as their surgeon. So it's my job to make sure my team is caring about the patient as much as I do. Shot. And when you care about somebody, you pay attention to the details and make sure that they have a good experience, a good procedure, a good whatever it is that you're doing for them. You don't just do it half-assed. And I don't tolerate half-assed. All right, let's see. Shot. Yeah. I cannot get it untwisted. Shot. We're definitely in. We're definitely in. But it's not disengaging from the tube. Any way to grab the tube?
Yeah, I'm gonna
Get a coker. Shot. There we go. Shot. All right, go ahead and get that out. Let's get the fluoro out. Just so everybody understands that works for me, that surgeries are hard enough, the patient makes them hard enough for me, okay? I don't need my employees making them harder. Everybody understand? So do your jobs properly so that we don't have to have these kind of conversations. I can go back to actually teaching people about spine surgery and not about how we have these types of issues. But we do live broadcasts so everyone can see the realities of surgery. Most people don't understand what happens in surgery. People as in lay people like you guys watching these surgeries. Surgeries can be very stressful, especially when the team is not doing their job properly for whatever reason. And it's not that the team doesn't know how to do their job, it's they know what they have to do, they just choose not to do it. And that bothers me. All right. Here we go. I'm very easy to make happy. As long as you do your job properly, do it to the best of your ability, I'm happy. Then it's just me versus the disease.
Stop.
Huh?
Stop.
Shut up, you punk. Don't you ever tell me to stop. That's the wrong thing to say. You don't clearly understand my personality very well. Go back to doing your research. Anyway, do we have any questions from our audience?
Yes, we have a question from Canes25 on YouTube.
Sure.
They ask, Doc, for degenerative changes at the occipital cervical junction bilaterally with lots of pain and clicking and popping, is fusion money treatment or is there any minimally invasive like laser? Thank you.
Well, you're welcome. So we get these questions a lot from viewers. What they don't understand is you can't make a diagnosis by description. You have to have more information. And the diagnosis is what drives the treatment, okay? So I could close my eyes, you give me a diagnosis, and I will tell you the treatment with 100% confidence that the treatment is the best treatment, the only treatment, and that it will be done 99% of the time without any complications, okay? But what you're never going to be able to tell me is the diagnosis. The diagnosis is the hardest part of treating back and neck pain. And lay people cannot make the diagnosis. Not even surgeons make the diagnosis. It takes a very special person to make the diagnosis. And there's probably 1 in a billion persons on earth that can make the right diagnosis. But once the diagnosis is made, then the treatment becomes very easy. It's obvious what needs to be done. All right? And the reason why there's so many people out there with back and neck pain living with it is that all those doctors are making the wrong diagnosis or they're providing the wrong treatment. Okay? It's that simple. Wrong diagnosis, wrong treatment. So when you ask me, I have pain in my occipital region, would a fusion be the only way to fix it? I have no idea what's causing your pain. You could have a vertebral artery dissection, in which case you need a stent, not a fusion. You need a vascular procedure, not a spine procedure. So the first thing you need to do is engage me to make a diagnosis. It's that simple. I will tell you this. Yesterday I had a phone call with an expert, director, producer, and distributor for films, okay? Because I'm going to make a film. Not that kind of film, don't get excited, Omar. But the kind of film that's a documentary, educational. So what did I do? The very first thing I did is I found this guy who I think is going to be really very helpful, like you found me. The next thing I did was I paid him $250 for a consultation. And he met me and we talked and we had a great meeting, okay? And after talking to him, he understands what I'm trying to do, and now he's going to work to try to help us achieve our goals. You understand? The consultation is essential. It doesn't matter if you're doing spine surgery or you're producing a movie. It doesn't matter what it is. Maybe you're buying a car. Maybe you're going grocery shopping. But you're going to consult some information. You're going to acquire some information, okay? Let's take grocery shopping. I'm buying bagels. I'm going to go down the aisle. First thing I want to know is, where are the bagels? Aisle 12. Okay, thanks for that information. Next thing I want to know is, what kind of bagels do we have here? Because I want an everything bagel. Oh, look, there's blueberry, there's sesame, but not an everything. Oh, wait, there's the everything. Now I found the everything. Next thing I want to know is, did somebody open this and mess with the bagels? So I'm going to look at it, inspect it. And I don't see any evidence of tampering. Thank God. Next thing I'm going to look at is the expiration date. When does this expire? Oh my gosh, it expired last week. I don't want to buy these, okay? So we use information every day to make decisions in our lives. And the spine is no different. So when people ask me, what should I do? My simple answer in basic English is, how the fuck should I know unless I have enough information? Okay? And I know more than anybody about the spine. Anybody in the world. So I know more about the spine than anybody in the world, and yet I cannot tell you what you need done by just hey, I got pain here. What do I need to do? My MRI showed a herniated disc here, here, and here. What do I need to do? I don't believe your MRI. I don't believe the radiologist. I have to look at your MRI. I don't make treatment decisions based on someone else's interpretation of a diagnostic image, okay? Ever. That would be like, you know, you putting your life in someone's hands that you don't even know who the hell they are. And you're asking them for life-saving advice, and they're telling you life-saving advice, and they could be very wrong, okay? They could be dead wrong. And then you're the one who pays the price for it. So your source of information has to be reliable. Reliable source of information. If you don't have a reliable source of information, then you're making decisions based on bad information. And that's not something I will ever intentionally, consciously, knowingly, willingly do. So don't ask me what the right treatment is for pain here and here, okay? I will not be able to tell you. Now, you do a consultation with me, I make a diagnosis, I'll tell you what needs to be done. But not until I see your MRI, and I need a recent MRI, and not until I examine you with my eyes and my body or your body, feeling, touching, understanding your spine and where the pain's coming from. So don't ask me questions like that to tell you what the right treatment is when I don't even know what your diagnosis is, okay? Next question.
No current questions, but we do have another a comment from Billy on Facebook. And their comment was from seeing the fluoroscope earlier. They said, looks like anterior retro.
Yeah, it's not called anterior retro. It's called anterolisthesis. Antero means forward. So L4 is slipping forward on L5. So it's an L4 anterolisthesis on L5. That's the proper way to say it. Okay? Retrolisthesis is when the upper vertebral body is slipping backwards on the lower vertebral body. So L4 would be going backwards in a retrolisthesis. So antero means forward, retro means backwards. They're Latin terms, they're medical terms, standard terminology in the field. It just refers to a direction, whether you're going forward in the front of the body or backwards. Retro is backwards. You guys all know retro. right? Retro parties, 80s parties. This is all part of the herniation, by the way. I haven't been talking very much about the actual surgery itself, but if you look at the glass thing, that's the laser fiber. A lot of people don't understand. This is all herniation. The white stuff is some scar tissue and calcium. And this blue thing that has a glass is a laser fiber. Okay, it's called a laser fiber. And the laser fiber transmits energy from the machine that's at the patient's foot down there. It's a $125,000 machine. It generates laser energy, and that is transmitted from the machine right here to the very tip that I'm using to do the surgery. You can see some calcium there, but mostly we're removing the blue stuff, which is the degenerated nucleus pulposus. Okay? This is the anterolisthesis right here. You can see to the right is the L4 vertebral body, and to the left is the L5 vertebral body, which I'll show you in a moment. This is the back of the L4. Here's some herniated disc stuck behind the L4 vertebral body. That right there is the posterior longitudinal ligament right there at the tip. A lot of scar tissue from inflammation. That's the white stuff that's like, looks like it's, I don't even know the right word for it. There's no food that describes it, but normally I describe things with food, keeping with the tradition of pathologists for centuries. Pathologists were always considered the teachers of doctors for centuries. Pathologists were the teachers of doctors. Are we good on irrigation? Yes. And the reason for that is that, think about it, what is medicine? It's really the treatment and prevention of disease, right? So who are the disease experts? Pathologists. Maybe you don't know that. Pathologist is a doctor, a medical doctor, who studies diseases in tissues and the body, and they describe the anatomical and histological and cellular and genetic abnormalities that make up the diseases. So they teach the doctors how to look for disease and ultimately collaborate with doctors on how to cure disease. We know so much now about diseases in the human body that the role of the pathologist has sort of been pushed to the side, and they really don't get the credit that they've deserved historically for the work they've done to elucidate the basis of human condition and disease. Without the work of early pathologists in 100 years, 200 years ago, 300 years ago, medicine would not be where it is today. We would not be curing diseases. All right, any other questions?
No current questions, so we do have two comments. This first one comes from Canes25, once more on YouTube. And they said, if I end up having to have fusion for this noons doing it, but you, that's for sure. That's what I'm trying to understand. If I end up having to have fusion for this noons doing it, but you, that's for sure.
No one's doing it but you.
Oh, okay. No one's doing it but you.
Yeah, I appreciate you saying that.
Yeah.
But again, the key is, I don't know if you need a fusion. I don't know what's causing your symptoms, but I could tell you if I could examine you, and I could see your MRI. That's important. Now, sometimes we need additional tests, like a CAT scan or a nerve test. But generally speaking, I can make most spine diagnoses just with an MRI scan and a physical exam.
They also commented, Canes25, they said, I'll be getting in touch as soon as my ortho doc does both ulnar elbow decompressions.
Sure. Good luck with that. Hope that goes well for you.
And we have another comment from Billy, once more on Facebook.
Well, before we get to that, just final comment on Haynes. He brings up a really good point, which is that sometimes the pain people get in their arms is not coming from a pinched nerve in their neck. It's coming from a pinched nerve in their elbow or their forearm or their wrist, or even from a muscular inflammation where the muscle attaches. We call it tennis elbow, or even the shoulder. So there are, you know, many causes of pain in the arms, symptoms in the arms, but as far as neurological causes, the pinched nerve in the neck from a herniated disc or spinal stenosis is the most common. And the second could be the pinched nerve in the elbow or wrist, called ulnar neuropathy or carpal tunnel syndrome if it's in the wrist. Just so people are aware, pinched nerves happen in more places than the neck. They happen in the arms too. And that's why we do nerve tests to make those diagnoses. Okay? I appreciate your comments, and I would love to be the one to fix you if you choose to have that done. What was the other comment? We're almost done with this disc. Just about another 30 seconds.
You have the comment from Billy Jones on Facebook. They said, this view looks really large. Is it like the size of a quarter in the area that you are working?
Yeah, great question. So from the left side of the tube to the right side is about 5.5 millimeters. 5.5 millimeters. And that fiber, the glass fiber right there, is 1 millimeter. So if you measure from one side to the other, you've got about, about 5, maybe 5.5, okay, diameters. So it's very small. It's smaller than a quarter, smaller than a dime. It is about half of the width of a dime. Half of the width of a dime. You can see we've gotten rid of almost all the herniation with the laser. Just about done here. And I feel really good about it. We've done a good job. The patient is sleeping beautifully. He's not moving or doing anything. And I was talking earlier, for those of you who are listening, about the challenges of these types of surgery. And, you know, every surgery has its own challenges, but some of them are medical airway challenges, anesthesia challenges, basically. And then others are anatomical challenges or surgical challenges. Challenges for me surgically, you know, because of the patient's anatomy. Whether they have a high iliac crest or they're heavy set, or they have a spine that's very anterior. Those are all anatomical challenges. And the anesthesiologist in this particular case has airway challenges. He's dealing with a patient who has severe sleep apnea, and they have a machine that they use called the CPAP. Maybe you've heard of it, and they've brought it with them. And so we're doing our best not to put the patient too far to sleep, because if they're too asleep, then they don't breathe very well, and we have trouble managing their breathing and ventilation and oxygen exchange. But you got to keep them somewhat lighter when they have those kind of problems, okay? Which means they may move around a little bit more. But you have to accept that. You have to accept that extra moving around as part of the surgery, because you can't put them any deeper. It's not safe for the patient. They could stop breathing. Anytime you're doing propofol anesthesia, there's always a risk of that happening. And we want to reduce the risk. All right, I'm just about done. I think maybe just a few seconds here. This is all ligament right there, foraminal ligament, the white thing. And then you got fat. And I'm trying to clean out as much of the herniation between these two bones. That's the end plate of L5, the end plate of L4. And this is just a little bit left of the herniation. By the way, people ask me this, can you get an MRI afterwards? You can, but you don't need it, because I need the grabber. We don't make treatments based on MRIs. We make treatments based on symptoms. And the reality is that there is no disc that will look normal after treatment, okay? You're not going to make a disc look normal with any treatment, whether it's Deuk laser disc repair, artificial disc, fusion, laminectomy, discectomy, whatever medical intervention you choose for a disc problem, it will never be normal again. There is one exception, and that is taking somebody's spine out surgically and putting another person with a normal spine in there, okay? Which nobody does, by the way. They've done experimentally on animals, but That's never going to happen. Can't do it. Not with the nerves and spinal cord being there. And the reality is there's no purpose. The reason why they're doing it is to try to get rid of back pain. But we can get rid of back pain with a simple surgery. So I don't see there ever being a need for a spine transplant, though there are some countries doing it experimentally. Laser. All right, so that should be it. I just grabbed out as any other residual herniation. I don't see any more. We got it all. We've gotten, I always tell people you need to get about 50% of the herniation to get rid of the symptoms. And it's not the herniation, but the annular tear, etc. Let's just say 50% is what's needed. We typically get 80. Sometimes we get 90. I've never gotten 100. No surgeon in the world has ever gotten 100. It's not possible, and it's not necessary. Okay? It's called gilding the lily. There's no need for it. You're just putting the patient at risk if you stick around longer trying to get more stuff out that you don't need to be getting out. You can actually cause harm. Ultimately, the goal of the surgery is get rid of the back pain from the discs and decompress the nerve roots if they're being compressed, and stop the leg symptoms or set the leg symptoms up for, healing and reversing the symptoms over time. So why do people get leg symptoms from a herniated disc? Number one, inflammation on the nerve root. Number two, pressure on the nerve root. It's very rare that there's that much pressure on the nerve root. And when you get pressure on a nerve root, the symptoms are weakness, numbness, and tingling. Weakness, numbness, and tingling, not pain. Everybody thinks pressure on the nerve root causes pain. Pressure on the nerve root never causes back pain, ever. It never causes leg pain. Pressure on the nerve root causes weakness. Come on in. Numbness in the skin around the foot, weakness around the foot or upper thigh, and tingling, paresthesias we call it. Okay? I see all these people in spinal stenosis groups talking about how they're having so much back pain from their spinal stenosis. They're not having back pain from spinal stenosis. That is not true. They just don't know that. Spinal stenosis doesn't cause back pain. Spinal stenosis causes neurogenic claudication, which is weakness, numbness in the legs with standing and walking. It gets better with sitting. Thanks. And it's due to pressure on the nerves when you're standing and walking. Okay? Shot. Next disc is L3-4. Shot. I can feel an annular tear. It's pretty big. Shot. Hold on. Shot. Take it out. Yeah, that's, you already did or you want to? I did. Thanks. Perfect. Little pressure. Yep.
That was good numb.
Huh?
That was really good numb.
Which one? This?
Right here.
Oh yeah.
This was sensitive disc.
Yeah.
You did very well. You didn't really arch much. Heart rate's great.
Well, I didn't know, is that your anesthesia or is it my anesthesia?
I think that's all you.
My anesthetic, or what is it called? Analgesia. Your anesthesia or my analgesia?
Yeah, non-anesthesia.
Right, so it's my analgesia, not your anesthesia. All right. Shot? Yeah, that's good. Yeah, go, go, go. I thought we'd have the shot of it out already. Very good. Thank you. Let's get the fluoro out. Any questions so far?
We have a few comments and a question.
Sure.
The first comment comes from Canes25 on YouTube saying, I'm going to get in touch and send you all the recent studies. I have an MRI, bone spec scan, and a CT angiogram.
Jesus. Interesting. I'm just curious, since you're out here professing, why do you have a CT angiogram? All right, yeah, you don't have to tell us, but at some point I would like to know, because it's unusual for people to get studies like SPECT scans and CT angiograms when it comes to the spine, unless there's concern for some type of a tumor or a vascular abnormality. So I'm just wondering if somebody was working you up for a tumor or a vascular malformation, like an AVM, dural AV fistula, carotid vertebral dissection, something vascular basically, which I don't treat, by the way. Not that I'm not trained to treat them, I am. I choose not to treat them because I don't provide the best treatment for those conditions. There are doctors that do a far better job than me. My focus is disc problems and joint, basically spinal joint problems. Facet joint, disc problems, sacroiliac joint, even some piriformis muscle down in the lower back. So I'm kind of curious to see. Anyway, I appreciate you sharing, and I look forward to trying to figure out what's wrong and giving you some advice. So thanks.
Our next comment comes from Barbara on YouTube.
All right, Barb.
And they said, I described the white fluffy substance in foodie terms as soft scrambled egg whites.
Ah, I like it. Soft scrambled egg whites. Yeah, but the problem is, Barb, there's several different types of white stuff here. And each one of them has a little bit different appearance, but also different consistency. And the consistency is really the main thing I was trying to describe. So for example, that right there is going to be part of the herniation and maybe a little bit of scar tissue on top, but you see the blue stuff is the nucleus pulposus. And the white stuff right there is some of the nucleus that's not stained yet. So it's too deep. It didn't get exposed to the blue dye because it was probably protected or buried. And then you've got the annular tear, which is also white. Then you got the scar tissue, which is white. And you've got the end plates, which are white. And you've, of course, got the nerves, which are white, but you don't see those. And then I think that covers everything. So you've got unstained nucleus. You've got annular fibers. You've got scar tissue. Come on, Luis, you're not. I don't know if you're not taking it off. Yeah. How's our irrigation? Because it looks like it's just not. Things aren't flowing out as well.
It's running well. Do you want me to turn the pressure up?
I don't know. As long as you feel it's running well.
Yeah,
I'm just trying to figure out why. So those are all the things that are white. There's many white things here in the disc, and the reason there's so many white things is because the disc doesn't have a lot of blood supply. Think about it. Blood supply is what gives tissues their color, a lot of their color. Okay? Like red muscle is red because it has more blood vessels in it. White muscle is white because it has less blood vessels. The disc is white because honestly it has very few blood vessels. It doesn't have much blood supply at all. Now there's a little bit of interestingness right there. You guys see that? That little bit of reddish stuff there inside the disc area, that is granulation tissue, inflammatory tissue. This is not one for the educational stuff. Don't worry, Henry.
Copy that.
It's not seen well enough for me to include it. Does that make sense? Yes, it's there, but it's not that good of a picture. See how that disc material is scarred right there? It's like I'm having to zap the scar connection to get it out. That scar tissue should never be inside your disc, inside the nucleus. That's not normal. So the only reason you can have that scar tissue there is when you have an injury to the disc with inflammation. So it just indicates the true inflammatory nature of this disease. Disc disease is an inflammatory condition.
We have a couple questions.
Sure.
These next two questions come from Best Sports Media TV on YouTube.
Sure.
And the first question is, I got an MRI. Can you explain what is annular bulge at L4 through 5?
Yeah, annular bulge means you have an annular tear and the nucleus pulposus is bulging out. It is a herniated disc, but it's a small herniation. From my experience, those are very commonly the cause of the back pain. They are probably the cause of your back pain. And they need to be treated. And the only way to treat them is with the Deuk laser disc repair, what you're watching right now.
Second question, they asked, how does the laser actually repair the tear in the disc?
Great question. Well, the laser, you see the inflammatory tissue right there, the pink stuff? If you go back and see right there, just a tiny little spot of it right there. See it when I turn around the corner?
Yes, we do.
You guys see it just like a wisp of pink tissue. All right, that is where all the pain fibers are inside a herniated disc. The laser delivers energy to the tissue. Look at it. Whatever the laser touches, whatever the fiber touches, whatever the laser energy is transmitted into, that tissue literally absorbs the energy and then breaks apart. So the laser delivers energy to a tissue, to a solid. The laser energy goes to the protein level, basically, of the disc, which is mostly collagen, and it literally gets absorbed by the collagen fiber, and it breaks the fiber apart by breaking the bonds between the amino acids. So proteins are made up of amino acids. Amino acids are small little molecules that are made up of carbons and hydrogens and a little side chain, you know, which could have a sulfur group, a fluoride group. It could have a sulfide group. But basically there are, I think, 21 essential 21 amino acids. Maybe the number's gone up. I'm a biochemist, but when I studied biochemistry many years ago at UC San Diego, there were like 20 amino acids, but I'm sure they've discovered more. Long story short, these amino acids are the building blocks. They're like Legos. And imagine Legos with 20 different colors, like red, blue, orange, green, 20 different colors. And you just start assembling these chains of Legos. You start attaching them together. And they're bonded together by a bond called a covalent bond. There are different types of bonds. There's ionic bonds, there's hydrogen bonds, there's covalent bonds. Covalent bonds are the strongest bonds between molecules in biology, and they're what hold the protein amino acids together in the primary structure of proteins, okay? So this laser energy gets absorbed by the protein and it goes straight to the bond between amino acids and breaks them. And that way they fall apart, basically. And it's happening to literally millions of little bonds at a time, wherever the laser touches. That's how the laser works. I would also say the laser creates a shock wave. The shock wave also, you can see things moving, so it mechanically kind of shakes things apart and shakes things loose. So if there's a piece of herniation that's somewhat loose, it will shake it and get it to get loose and come out of the tube so we can get rid of it. Great question on the laser, by the way. So for those of you who don't know, this is an FDA approved laser. It's manufactured in Israel, sold around the world, but we bought ours in the United States. And the fiber itself is also FDA approved. And it's approved specifically for uses like taking out prostate tumors or prostates, taking out stones from the kidneys, also removing disc material like this. So it is FDA approved specifically for this purpose that you're watching.
We have a comment from Best Sports Media TV on YouTube.
Yeah.
And they said, thank you so much. Send my MRI over, waiting for review.
Yeah, you're welcome. We look forward to helping you out, figure out what's going on, and recommending what's needed. Appreciate the support from some of our viewers. They follow us every week and watch our surgeries every week. All right, so far what we're seeing here is this is the annular tear, and I'm not even at the end of it yet. I'm kind of pulling the tube backwards, but you can see how thick the annulus is. It literally starts way up here and then it goes all the way down to here. So we're not removing the disc. People ask me, if you take the disc out with the surgery, what are they going to have left in there? And we're not removing their disc. We're actually just debriding the tear, getting rid of the nuclear material inside the tear. It's called the interposed herniation. And this is where all the pain comes from. Yeah, and again, this was discovered at Deuk Spine Institute, which is why we're the place in the world where you go to get your back fixed when you have back pain. Same thing with the neck. As a matter of fact, I think we have a neck cervical Deuk laser disc repair coming up on Thursday on a lady who's traveled to us from England, and she's here to have her cervical spine fixed. And of note, she actually first went to Korea, South Korea, where I actually learned the basics of the technique from the South Koreans, from a hospital system called Wooridal Hospital, spelled W-O-O-R-I-D-A-L. Anyway, the founder of Wooridal Hospital, Dr. Seng-Ho Lee, and his right-hand man, Dr. Gun Choi, they're both South Korean neurosurgeons. They personally taught me how to do the cervical endoscopic approach. However, then I modified it and added the laser because they weren't using lasers. And I actually also put my patients to sleep, which they don't do. There's a lot of differences between my technique and theirs. But anyway, she told me they're no longer doing cervical laser endoscopic surgery, which doesn't surprise me. I know they had some complications over there, and I think they cut back on doing cervical, and their focus is now lumbar. They offer fusions instead, which I think is a step in the wrong direction. You're going backwards. But yeah, just some interesting information. All right, we're just about done. This is the outside of the tear. You see that? We're now outside the tear. This is the surface of the herniation, the disc. Still a little bit of herniated disc in there. It's actually more than I expected. You can see the herniation material, which is white, because it didn't stain well with the annulus, with the blue stain. You can see how it's white, and it's stuck in between the fibers. See this stuff here? That's all herniation called interposed herniation.
We have a comment and a few questions.
Yes, this is all part of a bulging disc right here.
This comment comes from Canes25 on YouTube.
Sure.
And they said they did an anagram because I have severe onset of tinnitus that correlates with the neck flares up,
I see.
up top, and where the occipital issues as they were trying to diagnose.
I understand. Yeah, so if you had tinnitus, that's a reason, because they're going to look for a dural AV fistula as the source. I assume it came back negative for a fistula. But whenever somebody has pulsatile tinnitus, where it pulses with their heart, the standard is to rule out a dural AV fistula around their suboccipital region. All right, just about done here. I need maybe 30 seconds more. This is really a debulking, folks. Debulking, D-E-B-U-L-K-I-N-G. Debulk means to remove mass from. We're debulking the herniation, okay? And by doing so, the herniation gets smaller, it doesn't put pressure on the nerves, and it can heal properly. This will heal. This big crack right here in the annular tear will heal. It's just going to be a matter of time. So you can see some fat in the epidural space, okay, some blood vessels, but look at that hole right there. It's smaller now than the size of the tube. It's about 3 millimeters. So whenever we're done with the Deuk laser disc repair, we typically will see about a 3 millimeter hole. There's the nerve root right there. You guys see it? That white thing, that's the nerve. Look at the surface of it. It's scarred. All those white strands are scar tissue. And the reason it's scarred is because of inflammation that's been going on in the disc. That causes scarring on the nerve. But it's nice. We still see some fat around the nerve, which is good. That nerve I just showed you is the right L3 nerve root. Right L3 nerve root, specifically in the neuroforamen. Specifically, the part of that nerve root is called the dorsal root ganglion. Dorsal root ganglion. And that is where all the cell bodies are for the sensory nerves that go down the leg. And since it's the L3, it goes in the front of the thigh and wraps around immediately below the knee. So the skin in your leg in that area, if you touch it with your fingers and rub it, it's going to send sensations up to your brain. And the nerves responsible for those sensations, well, they're cell bodies, which is the business side of the cell. It's like the factory side of the cell. That cell body is located in the dorsal root ganglion, okay, for the sensory nerves. Not the motor nerves, the sensory. All right, we're done with the Deuk laser disc repair, and we're going to start now what's called the Deuk plasma rhizotomy. And thank you. And the Deuk plasma rhizotomy is a procedure where we're treating facet joint pain. And remember we talked about how there's different kinds of pain from different sources. And the first thing we have to do at Deuk Spine is diagnose your source of pain. Okay, you cannot treat someone without knowing exactly where the pain's coming from. Now, unfortunately, 99.999999% of doctors, nurses, physical therapists, chiropractors, they don't believe back pain comes from a specific location. They believe back pain is called non-specific or generalized, or they start using things like fibromyalgia, because what they're really saying is we have no clue where the pain's coming from. We just know it's coming from your back. But the reality is, in the last 20 years, we've learned so much about where pain actually comes from, and it actually comes from very specific structures. And our research fellow this year, Arias, who sometimes I got to put him back in line, but generally he does a really good job with the research and the data. Okay, he's been very helpful. And what we're finding is that 83% of chronic back pain comes from a disc, or more than one disc, okay? And that about 10%, really 9% of back pain, chronic back pain, comes from facet joints. This patient has disc pain and facet joint pain, both. So he came here and he wanted to be treated for both. All right, I've been putting pressure on the paraspinous muscles for a few minutes just to stem any kind of venous bleeding we may have from the DLDR. And now we're going to start with the DPR. So enjoy the ride. We're going to be targeting his facet joints. Shot? All right, so let's get that lined up a little better. Nice. All righty. There's 5. There's 4. We're doing 4, 5, 5, 1. Everyone agree? So I'm a little bit too north. I need to move south a little bit. Shot. All right, that's perfect. That's exactly where my target would be. Straight down. Let's see if I can hit it. And you're going to feel the bone. Shot. I think I went a little north or south. Yeah, I'm right on the transverse process. I could be a little more lateral. Hold on. Shot. All right, so almost there. There we go. Shot. That's a little too lateral. Just want to be a little bit more medial. There's the facet. Shot. Yeah, that's pretty darn good. I could be just a slightly bit more north. Shot. That's as good as we're going to get it. What do you think, Jordan? Yeah, he's got a small transverse process. You see that? It's kind of pointy and small. Uh-huh. So bring the fluoro up to the ceiling a little bit. That's good. So I'm going to make an incision right now. And that incision is to place my probe, the Deuk plasma rhizotomy probe. And now I'm going to treat his facet joints. How's blood pressure anyway?
120.
All right. So we're going to use this X-ray to get to that joint. Shot. And specifically, I'm looking for the medial branch of the dorsal ramus. Shot. It's right down there. So I'm on my way. It's looking like it's lining up perfectly. I've just got to land on the bone. There it is. I can feel it. I want to verify. And you're going to take a lot of X-ray pictures as you do this. You're not giving too much X-ray, but what you're doing is you want to make sure you're on the right spot. And as long as you use the X-ray guidance properly, you're not going to have an issue. And I'm using my X-ray. I can actually feel. That's another thing that I should talk to you about is feeling. Okay? What I mean by that is I have so much experience doing open back surgeries like fusions where I use this technique during the fusions for the last 25 years. I know the anatomy there perfectly well, so I know when I feel the bone, I know how to march the tip of the probe along the bone to make sure that I'm not going somewhere I shouldn't be. Because obviously, whenever you do surgery, you want to avoid getting somewhere you're not supposed to be. That could cause complications. So it's very important that you stay where you're supposed to be when you're doing surgery. All right, that's almost perfect. And I always shoot for as close to perfect as humanly possible. It could be a little bit more medial. There you go. Yeah, people are paying me and coming to see me for me to be as perfect as humanly possible, not to just stick it in and throw a Hail Mary. So we know exactly what needs to be done, and we're capable of doing it the right way. We have the right equipment, we have the right staff, technology, etc. So my expectation every time I operate is we're going to do it as good as humanly possible. And I won't settle for anything less than that for my patients. People come here with an expectation that, you know, we're going to do the best for them and fix them. And that's what I want to deliver to them. Almost done. All right, very close. I feel the TP, but I'm marching it along medially. So once you get to that spot on the TP, you see where I'm at, guys and gals? Right there is perfect, but I want to be a little more medial, but I cannot be a little more medial because I'm bumping up against the lateral wall of the facet. And that's the perfect spot, top of the transverse process where it joins the facet joint. And that's what I'm treating right now. I cannot get more medial. If I could get more medial, I would. Okay? Medial, show us what medial is. That's right. That's right where the arrow is. I would love to be a little more medial, but you can't because the facet is keeping me from getting more medial, and I'm scraping the side of the facet. So I know I'm right where that pain nerve is supposed to be. So I feel really good about that. We've hit exactly where we're supposed to be. And I'm going to do one more spot. If you want to show us the target, Jordan. Let's see. Yep, that's it. Shot? No, I don't need it. I just need to be a little more lateral. Shot? It's getting closer. All right, so that's about as perfect as you can get right there. Let's see that. Yeah, can't get better than that. So that's our last target. That's our last point. We should be done in about 5 minutes. Any questions for me, type them up. You've just watched 2 different procedures being done. One to treat disc pain, the other to treat facet pain. And this patient had both, okay? When he came to us, he had both. We knew he had both. We offered him both treatments at the same time. He accepted that, and that's what we're doing right now. We're doing both treatments. Type your questions up and I'll answer them for you when I get back to the broadcast area. I need to be more medial. Shot. Just about perfect, almost perfect. So I'm going to move it a little more medial. I cannot move it any more medial because of the facet. The S1 superior facet is blocking me. So I'm going to try just a little bit more. I can feel the bone. I can feel that spot. You want to be in the valley. Yep, that's perfect. So it took a few extra tries, but we got it. Any questions, like I said, feel free to type them up and I'll answer them for you. Okay? Almost done. 30 seconds. Shot. And by the way, because I'm moving the probe, I'm always going back and checking. You don't do that with an RFA. With an RFA, you put it, you leave it, and you're done, which is why the RFAs don't work. You have to move it around to get the nerves. All right, thank you everybody for watching, and thanks everyone here for helping. Great job. Type up your questions and I'll come answer them for you. Our next surgery will be another Deuk laser disc repair. What are we doing next, folks? Lumbar 3 levels. And that lady comes from Oklahoma. And a really nice couple traveled from Oklahoma to Florida to get the Deuk laser disc repair. She's got 3 bulging discs. The other doctors just kind of blew her off, told her it was in her head, all that pain. And she's been dealing with pain and suffering with pain for years. She lives on a ranch with her husband. She can't do the work she needs to do to care for the animals. And, you know, chronic pain robs you of your dignity for more than one reason. It doesn't allow you to do the things you want to do. It keeps you from doing your job. And if you're in a partnership with somebody, you can't do what you're supposed to do in that partnership. And you're relying on their empathy and sympathy every day because they're now carrying more weight and you're carrying less weight. It's horrible. So get your back pain fixed so you can live a normal life, a fruitful life, a dignified life. I'll be back to talk to you guys in a few minutes. Okay, Henry?
Copy that.
Good morning, I'm Dr. Deuk at the Deuk Spine Institute here in Melbourne, Florida with one of my patients who traveled from California. He's been suffering with his lower back pain for years and found us on the internet and decided to come here and have the endoscopic Deuk laser disc repair. We performed that 12 hours ago and here you are, ready to go back to California, it looks like. How do you feel?
I feel great. It took a long time to get to you. Surgery was quick and painless. I don't remember a thing. Your staff was wonderful, but I am pain-free.
That's awesome. Yeah, and you're going to stay pain-free. We don't have you on any pain meds. We don't have you on narcotics, killing your pain. We didn't put any medicine in your back to stop your pain, so what you have is natural. And do you feel that pain anymore that you had before you came here?
No, the pain is completely gone. In fact, I quit taking my own pain pills 2 or 3 days before I got here, and I am on no pain pills at all, and I feel wonderful. When I woke up this morning, it was a different day, and I feel great.
And I feel wonderful for you for doing that. That's why we do what we do. We can cure pain, and we want everyone to know that, because nobody should have to live with pain every day. How does pain affect your life every day?
Pain is traumatic. The kind of back pain that I was suffering put me in bed. And for the last 3 months, I have been absolutely useless. Absolutely useless. And so I found you. It took me a few months to get here, and it was worth the trip.
It will be for the rest of your life.
Absolutely.
Worth the trip. Pain robs us of our dignity, doesn't it?
It does. It absolutely does.
And your parents are here, and they're very supportive, and that to me is so important, that you have people that understand what you're going through. I'm sure your parents have been a big support for you.
Oh, absolutely. Yeah, I was at work, a short story. I was at work last Wednesday dealing with this pain, and my back finally gave out to where I literally could not walk anymore. And I was 600 miles from home, and so I called my mother and father. They flew to San Diego and arranged the trip to get here. I called your place. I was scheduled for February 2nd, and I asked Richard on the phone if he could get me in sooner, because I was desperate. And you guys got me in a week or two sooner, got me in the 24th, which was yesterday. And so we made the arrangements, and I flew here, stayed in the hotel for a couple days, and was operated on yesterday. And yeah, it's well worth the trip. I apologize for getting emotional, but it's been a long trip to get here.
Well, we want you to get emotional, because it is an emotional thing. When you've been burdened with this pain for so long, and then suddenly it's gone, and you realize that life can be lived without that pain, you know, and that you can actually have a life without the pain.
Yeah.
So what are you going to do now that you don't have the back pain anymore?
Well, I'm going to get my life back together. I've got a new job, and they've saved it for me. My boss is wonderful, and I'm going to go back to work tomorrow, actually, if you can believe that.
Yeah.
And I'm going to start riding my bicycle again and getting healthy again.
Well, your surgery went very well. I don't know if you've watched it yet, but we were able to get in with a tiny 7mm 1/4" incision and fix both painful discs, and they were both very painful for you. And the pain was coming from a small tear that's located in the back of your disc where your herniation came out of. And that tear was just so inflamed, and we were able to clean out the herniation that was stuck in your tear and use the laser to debride it. And that's what the Deuk laser disc repair is. It's a debridement of the annular tear to eliminate back pain and leg symptoms. So we also have a cyst. We didn't treat your cyst. And do you think the cyst is causing any problems for you?
At this point, no. I don't think so, because all of my symptoms are gone. This morning when I woke up, I was a little nervous about getting out of bed. But that subsided quickly when I stood up and could stand up completely erect with no pain or bindage feeling in my back.
Yes, when I walked in and saw him this morning for the first time, the first thing your mother said was, "Look how straight he's standing." So they must have watched you suffer for a long time.
Oh yeah. Yeah, my mom's a great lady. I'm blessed to have her in my life. And then that's my stepfather, Jerry. He's a wonderful man. He and I are pilots. We fly together. We do a lot of things. And he's seen me go downhill. He knew something was wrong, you know.
How did you find out about us?
I've been seeing a chiropractor in Sacramento for 35 years. And 2 months ago, I started to really feel bad. And I would go to him. And after about a month of going to him, and going to my doctor for some pain management for these symptoms, I finally figured out that something else was wrong with me. And so I asked the chiropractor, what can we do, because what you're doing is not helping me. My doctor put me on pain meds, and they took some of the sharp pain away, but nothing was helping. And so, being kind of a mechanical engineer, I decided to look into how my back was put together. And I requested an MRI from my doctor and from my chiropractor. And so that took 3 weeks to schedule. That's a long story. And I finally got an MRI, and I looked at it myself and realized that I had a cyst of some sort and that I had some problems with my lower discs. And that's when my chiropractor told me about you. He said, get on the internet and do some research and then call these people. So I called your store. They gave me some information. I FedExed my package to you guys, and a week later you called me. And about a week or two later, I got here.
Wonderful.
So, yeah.
And here you are pain-free for the first time in many years.
Many years, many years.
Congratulations.
Yeah. Thank you.
Is there anything you want to say to your fans out there?
There is. This is a miracle. In Sacramento, everybody that I know said, why are you going? Why are you going to Florida? Why don't you find somebody in Sacramento? And I said, well, because I was referred to Dr. Deuk and I've done a bunch of research on him, and I just have a great feeling about him. Not only that, he personally called me on the telephone because I told his people that I had some questions. And that's what sealed the deal. And so it took a while to get here, but it was worth everything. And I would recommend anybody send your MRI to this guy, and if he can help you, he will. Okay? Thank you, Doc.
You're welcome, sir. It's my pleasure.
Yeah, absolutely.
All right, go enjoy the rest of your
All
life.
right, thank you.
I'm Dr. Ari Deuk at the Deuk Spine Institute, here with a patient from Virginia who came out to the Deuk Spine Institute yesterday for surgery, and we fixed 2 discs in his lower back. You were having back pain for some time. Do you still have that same back pain?
No.
Gone.
I feel, my back feels 100% this morning. I was able to sleep in the bed, laying flat for the first time in 2 months. I was sleeping on the couch for those 2 months, and I did not get good sleep at all. So I feel great in my back.
Good. Well, that's why we're here. We wanted to cure your back pain and give you quality of life back. What was life like living with that back pain?
Any day you'd be like, it could happen today. I could go down with back pain, severe back pain for a week. And that happened. My first pain started about 5 years ago. I was working in the flower garden. I went down with severe pain. I was down for probably a month that time. And ever since then, it was just like randomly, just out of the blue, I'd go down for another week with severe back pain. It was just no way to live because I knew every day waking up it could happen today.
Yeah, it is no way to live because then you got to be careful every day. You don't set it off. You're worried about it. You're thinking about it. It takes control of your whole life, that back pain. His back pain happened to be coming from 2 discs. And did you see any other doctors? Did they recommend treatment for you in Virginia?
Yes, I was seeing chiropractors for the first number of years. The first chiropractor, he put me on this decompression table, and he would, pull you apart. I did that for 6 weeks. I felt a little relief at first, but it didn't last very long. And I've been seeing just regular chiropractors throughout the years as well. And then when this happened, I saw an ortho doctor. He did not recommend surgery. He recommended physical therapy. He said surgery it's like a coin toss. It either works or it doesn't. And that was not good enough for me. I needed a little bit more reassurance that it's gonna work. That's when I started looking for other options, and I had a lot of time on my hands. I did a lot of research, and I found Dr. Deuk here, and I started watching his videos and testimonials. Made up my mind right there. It was without a doubt that was my choice right there. I submitted my MRIs, and within 2 days I did my virtual consultation with you, and 10 days later I'm here.
Yeah.
And it's amazing. I had an appointment with an orthopedic doctor in Charlottesville, and that was February the 2nd for my first visit, just for a consultation. And who knows how long it would have gone after that.
Years.
And yes, I'm done now. It's just, I'm back to recovery, you know.
Yeah, the problem is, unfortunately, the vast majority of doctors treating back pain don't know how to cure it. They just don't. And if I had to put a number on it, I'd say 99% do not know how to cure back pain. It really comes down to two things. You have to make the right diagnosis. Where is the pain coming from? Most doctors really don't even know it comes from the disc, and that's where it comes from about 90% of the time. Then the second problem is knowing how to treat it. And the treatment that works, the only treatment that works, is surgery on the herniation, really. And there's two surgeries that work, fusion and the Deuk laser disc repair. I've done fusions for years. I've cured people's back pain with spinal fusions, but that's a big, bloody, messy surgery with screws, rods, cages, long recovery. You're on opioid painkillers for months, like 3-6 months, just taking painkillers, just getting over the pain from the surgery. Not the back pain, pain from the surgery. So when we started doing the laser surgery, people weren't having any back pain afterwards. They'd have just a little discomfort for one night. We realized they didn't even need the opioids anymore. So our laser patients don't get any painkillers except Tylenol and usually one or two Robaxin. So you did it. You happy you did it?
I'm very happy.
Yeah. And you can see in the surgery that we did, we actually got into your disc. We used the laser to clean up those tears at L4-5 and L5-S1. Surgery went really well for you. We didn't have any problems. It was just a tiny Band-Aid incision on your back, and that's why you went home an hour later, and that's why you're here today, ready to go home. Where are you guys heading back to Virginia?
This afternoon.
Driving?
No, we're flying.
Flying out of Orlando?
Orlando.
Awesome. Anything you want to say to your friends and family and people you know out there?
Yes, living in pain is hard. It's not a way to live. And I recommend Dr. Deuk any day.
Well, thank you. I appreciate that. You had faith, and you're going to be rewarded for that. Congratulations.
Thank you.
All right. Good to see you. Two, one. And welcome. I'm Dr. Deuk Majin. We have just completed a surgery on someone's back. This person presented to us with 40 years of lower back pain, 40 years. And in 40 years, the doctors could not figure out what was wrong. He contacted Deuk Spine, and in 5 minutes, we made the diagnosis. We did it through a virtual visit where the patient actually showed us on Zoom where the pain was, and we looked at the MRI, we reviewed it together, and I came up with a treatment plan for the patient. The patient is now here having a surgery, and 40 years of back pain I expect to be gone. His pain was localized to two discs, the L3-4 and L4-5. We, during the surgery, tested those two discs to see whether they were painful, and indeed they were. They created 10 out of 10 back pain when I injected a little bit of dye in them, just to test them to see if they were painful. Now, a normal disc would never be painful. A normal disc does not hurt when you inject dye into it. You don't even feel it. You have no idea it's there. So we call that procedure a discogram, and specifically an evocative discogram. Evocative means you're evoking a response, and as opposed to a chromodiscogram where you're not evoking a response. The difference has to do with of course, the mental status of the patient, the level of consciousness specifically. Are they awake? Are they able to respond? So an evocative discogram, the patient has to be awake. They can feel the dye going into the disc that you're testing, and if that disc is one of their painful discs, they will say, ouch, that hurts. And you'll say, how bad is it on a scale of 1 to 10? They'll give you a number, 10 being the worst pain of their life, 0 being no pain. And then you ask the patient, is that pain that you typically feel every day? Because it's important. You don't want to be creating a new pain they've never felt before. So as long as you make the right diagnosis as the localization of the discs that are causing their back pain, you do the discogram, you're going to confirm that that is indeed their daily pain. We call that concordant. So if you go back and watch the video, you'll see me put a C. It stands for concordant. Don't ask me what it means. All I know is it means that's where their pain typically is. So it has something to do with, maybe it's Latin, I'm not sure. I could ask my Latin expert over here. He could tell me what concordant what the origins of it means, but in the business of spine care, it means that the pain the patient is feeling at that moment is their typical pain they get every day. That's what we call it. It lines up. So I confirmed that the L3-4, L4-5 discs were indeed the source of his pain. We did the annular debridement with the laser and cleaned up the tear, removed the interposed herniation. And of course, we did a rhizotomy as well, a Deuk plasma rhizotomy, which was to treat facet joint pain, which he definitely had on his preoperative exam. He had pain over the L4-5, L5-S1 facet joints. So I expect his pain to be gone. Hopefully we'll get a nice testimonial out of him. Our next patient is coming from Oklahoma. She has 3 damaged discs. When you look at her MRI, 99.9999% of doctors would say, we don't know where your pain's coming from. And that's what they told her. They told her it's all in your head, you're imagining it, there's nothing wrong with your back. The problem is, folks, people with chronic back pain, they get marginalized by society. They get basically discriminated against for having back pain. They're treated worse. They're treated badly. They're not treated better. Like if you're an NBA basketball player, right, playing for the LA Lakers, people look at you and they treat you differently. They treat you better. But when you have back pain, chronic back pain, people look at you differently and they treat you worse, unfortunately. Whether you're an employer, maybe you don't want to give that person a job, whether you're a person who's interested in them emotionally, whether you're their spouse or their children. People with chronic back pain, they don't get preferential treatment. They get worse treatment, unfortunately. That's because there's a stigma attached to chronic pain. That stigma is that these people are lazy and they're faking it. And that is the furthest thing from the truth. The pain is severe and debilitating. It affects all their life. These people are very sad and they're miserable and they suffer. And that's why I'm drawn to them. I'm drawn to their suffering. I want to end their suffering. I want to give them back a normal life. My entire life, I say this because it's true, I felt badly for people that are suffering. Empathy. And now I'm in a position where I can help those people get better. Unfortunately, I can't fix all suffering, but it would be nice if other people took some responsibility with that besides me. But when it comes to back and neck pain, I can help people get out of their suffering. At Deuk Spine Institute, that's what we do every week when we treat patients with pain. All right, we'll take our questions. Apparently we have a lot.
These first 2 come from Barbara on YouTube.
Hi, Barbara, on YouTube. Thank you for typing in some questions.
And they asked, what happens with all the microplastics flying around? That was like midway through the endoscopic surgery. And then, are you physically holding the laser and using a monitor to guide you?
Hi there. Yeah, so the first question, what happens to all the microplastics? I put that in quotes because there are no plastics, obviously. What's flying around in there is the broken up herniation that we're zapping away with the laser. And what happens to it all is it comes up and out of the tube. So we remove it from the body using fluid irrigation, sterile fluid irrigation. As far as the laser goes, what we do is I'm holding the laser fiber in my hand and I'm moving it around. So when you're watching, you're seeing the laser zapping specific areas. Those areas are what I'm targeting as the surgeon. I'm literally moving the fiber and I'm moving the scope, and by moving the 2 of them and twisting the fiber, moving the fiber, twisting the scope, I can move that laser fiber tip into whatever position in that circle of the tube, the inner diameter of the tube that I want. And so, yeah, it's targeted by the surgeon, and I'm looking at a monitor, just like you are watching the surgery, looking at your computer monitor or your phone. I'm looking at a monitor so I can see exactly where the tip is, and I'm using my surgical skills to move it around to, it's called ablating or removing through vaporization the abnormal tissue. Good question.
Next question comes from Jules on YouTube. And
Hi, Jules.
they said. So besides removing excess scar tissue and inflammation, does clearing out the nucleus help? What about clearing out the nucleus? Does it help with healing?
Yeah, so, our new website is going to explain, I think, in nice visual representation what we're doing. But if you watch the video that was played at the beginning, and if you go to our YouTube channel, I'd strongly recommend all the viewers visit the Deuk Spine Institute YouTube channel. We have thousands of videos. They're all organized into different playlists. So if you're looking for cervical, you could look at the cervical videos. But there's a playlist called animations, and what it really is it's the video animations we created that will show you exactly what's being done in the Deuk laser disc repair. So, but since you asked, there's a wall around the disc called the annulus fibrosus, and it's thick. It's around 24 layers of collagen thick. And when you get into an accident in your lifetime, you fall, or you fall off a horse, or you get into a car accident, I mean, anything, right? Any kind of trauma to your lower back. People say to me all the times, I don't remember any trauma. And I say, well, just go watch Fail Army on YouTube. And you'll see people like when they're younger jumping off of roofs with their skateboards, or, doing all kinds of crazy things. Point is, some of those activities result in trauma to your spine. And when it does, it rips a hole in your annulus. And now that there's a hole there, the jelly in the center, which normally is not supposed to escape, it starts to push into the tear and create inflammation within the tear as your body tries to destroy it. So it's that inflammation happening within the annular tear in response to the interposed nuclear material within the tear. That is the source of the back and neck pain or thoracic pain when it comes from a disc. That's what we're targeting, is that tear. So I'm ablating the nuclear material stuck in the tear. I'm ablating the edges of the annular tear that are full of scar tissue and what is called neovascularization, neoneurulation, which are basically pain fibers, unmyelinated, very sensitive to inflammation signals and cytokines. And without getting into too much technical biochemistry, basically you're getting rid of the area, the damage zone of the annulus that's causing all the pain. That's what the Deuk laser disc repair does. There's no other surgery on earth that does it. We're the first to do it. We're the first to publish it. And we've been doing it for 16 years, since 2006, I think. 6 maybe. And we're the only ones that target the tear right now. I know there's some other surgeons that I've been training through videos that are starting to do the same surgeries in other countries, but if you want to get rid of your back pain and you have a bulging disc, herniated disc, degenerated disc, we can fix it for you in one simple surgery. Takes an hour to do, an hour recovery, and then you go home. And it's done for the rest of your life. Okay?
And then lastly, we have comments from Kings25, and this was in conversation when we were talking about the EMGs mid-surgery, and they said, you are absolutely correct about the EMG. For years, I thought the arm/hand symptoms were coming from my neck, and I let it go, and all sudden symptoms progressed fast, and EMG showed elbow compression. It's been a long journey, and Doc, you have helped me along the way answering my questions. I thank you, and I know what I need to do now moving forward to get in front of you for neck.
Thank you. Yeah, that's why we do these broadcasts, to help people, believe it or not. Our goal is to share information. Obviously, I'm a busy doctor with many things, but I like to take the time when I'm operating, because it's a big chunk of time in my day where I'm not doing anything but operating. And I know that sounds funny, because most of you think, well, shouldn't you just be focusing on the operation? Once you do something over and over and over again, you can actually start thinking about other things. For example, my son races cars, and he'll get out on the racetrack and he'll be driving by at 160 miles an hour, and then he'll raise his hand and wave to us in the stands, and I'm like, how could he possibly be thinking about his fans when he's going 160 miles an hour coming up on a hairpin turn? So it's funny though, but once you get really, good at doing something, they call it muscle memory. It's not muscle memory. It's actually the cerebellum, the small part of your brain back here. It's responsible for motor actions that are highly programmed, like that you've done so many times, playing the piano, driving a race car, operating. It's the same thing. I can sit there and operate for hours, and I could be thinking about anything but the surgery. Once in a while, something unusual happens and you need your attention. But surgeons all around the world, it's not unique to me by any means. All surgeons can be distracted, during surgery. Some of them listen to music, some of them have conversations in the operating room. Some of us yell at our staff when it's appropriate. But the point is, you can do things other than just operate. And for me, I think, hey, here's a giant chunk of my time. I could teach people things. I could answer questions. I could show things. I could teach. That way people have a better understanding of what's actually going on in spine. And I can, unfortunately, in 2023 and all of these previous years, there's so much misinformation about spine care that somebody needs to educate the public about the truth. So I put 2 and 2 together. I'm operating. I'm not really doing anything for an hour. I might as well teach and dispel some of the myths and fallacies that are associated with spine care. So thank you. I enjoy it, and I'm glad that it's helped you and many other people.
Last but not least, we have a question from Oz on YouTube asking,
Hello, Oz.
can you do pull-ups or heavyweight lifting after lumbar spine fusion?
Oz, great question. So I'm going to recapitulate the question. Can you do heavy lifting or pull-ups after lumbar spine fusion? Great question. So first of all, if I did your fusion, you would be able to do heavy lifting of weights. But fusions are done differently by different surgeons. If there are 10 surgeons doing a fusion, you will have 10 different fusions, I guarantee it. No 2 fusions are the same. If you have 100 surgeons doing lumbar fusion, you will have 100 completely different surgeries. So when you ask me if you can do these activities, if I did your fusion, the answer is yes. But I would not recommend those activities for some other surgeon's fusion, because I know that 90% of spine surgeons, their fusions are very poor quality. And if you did that, you'd probably create problems, either where the fusion's done or around it. So I would recommend you talk to your surgeon, specifically your surgeon, and ask them what they recommend.
And that is it.
Thank you for joining us. We'll be back again in 20 minutes for another